Very good morning. I bring in greetings from Indian Society of Gastroenterology. We are coming with yet another masterclass series, that is series 5, and a new lecture on a very important topic of cystic lesions of the pancreas. And we have a very eminent faculty and a leading gastroenterologist who was the Secretary General of Indian Society of Gastroenteroscopy of India, who is at Delhi. Dr. Rajesh Puri is moderating, and we have the speaker, Dr. Sudipta Dhar Choudhary. So, Dr. Rajesh Puri is a well-known figure in India. He's the vice chairman in interventional gastroenterology and in the Institute of Digestive Disease and Hepatobiliary Sciences in Medanta, Gurugram. So let me request Dr. Rajesh Puri to take over and introduce the speaker and the subject. Dr. Rajesh Puri, please.
Thank you, Dr. Matthew Philip, sir, for giving the introduction. And I would like to thank the ISG, Dr. Govind Makharia and Dr. Matthew Philip. And the today's session, the speaker will be Dr. Sudipta Dhar Choudhary, Professor and Head Department of Gastroenterology, Christian Medical College, Vellore, India. And he's a well-known figure in the pancreas. And he's going to talk on the approach to the cystic lesion of the pancreas. And I request Dr. Sudipta Dhar to take the proceedings.
Thank you, Dr. Puri, for the kind introduction. I'll just start sharing my slides. At the very outset, I'd like to thank Indian Society of Gastroenterology, Dr. Matthew Philip, Dr. Makharia for giving me this opportunity. And also, I would like to thank Dr. Rajesh Puri for chairing the session. Without much ado, I'll just start off with this topic, which is approach to cystic lesions of the pancreas. Just to confirm, tech support is okay with the voice and the images?
Yes, everything is fine.
Thank you so much, sir. So, would you like to start with the quiz, sir?
Yes. The technical team, can you start the poll question? Okay, stop sharing. Sudipta, can you please stop sharing?
Just a minute. Yes, sir. Done. So I'll start off with this clinical case, which was of a 50-year-old lady. Staff who presented to the emergency department history of diffuse abdominal pain for 3 days, and this increased over the last 24 hours. On admission, her amylase lipase was normal, liver function test was normal. She underwent ultrasound in the emergency department itself, which showed a subserosal uterine fibroid. However, there was also an additional finding of a well-defined intraperitoneal cyst in the left upper quadrant measuring 68 into 70 into 78 millimeters. Next slide, please. This is the two images. On the one side, you have the CT scan image showing a well-defined cystic lesion arising from the tail of the pancreas. The MRI CP also shows a well-defined cystic lesion in the tail of pancreas, the unilocular cyst without any septations. So the next question. So now the question that we have is, what is the possible diagnosis here? Are we dealing with a pseudocyst, a mucinous cystic neoplasm, a branch duct hyperemia, or is it a cystic degeneration of a neuroendocrine tumor, or maybe even an intraductal papillary mucinous neoplasm? Now, this will be off for voting.
Yeah. Can we have the poll now?
Okay. So everyone says it's a mucinous cystic neoplasm. Let's see how it goes.
Okay, then you can, Technique, please stop sharing your slide, and then Sudipta, please share your slides. Yes, seeing the slides.
Okay. So just to give you a brief what pancreatic cystic lesions are, these are well-defined fluid-filled lesions in the pancreas. They are often detected incidentally because of the high use of cross-sectional imaging for a myriad of reasons that we have today. If you look at the incidence of prevalence of pancreatic cystic lesions on MRI, the incidence is around 16%, ranging from 13 to 18%. What is more interesting is that as the age increases, the incidence of pancreatic cystic lesion keeps on increasing, and the highest is in the age group of more than 80 years, where it's between 25 to 52%. Now, pancreatic cystic lesions can be non-neoplastic or neoplastic, and they are primarily classified into epithelial and non-epithelial. The non-neoplastic cysts include, which are epithelial origin, include simple cysts, retention cysts, congenital cysts, endometrial cysts. And the non-epithelial cysts include the pseudocyst and the parasitic cyst. The neoplastic cyst includes IPMN, mucinous cystic neoplasm, cystic neoplasm, solid pseudopapillary epithelial neoplasm, or SPEN as we call it. And interestingly, we also have some cysts which develop as a degeneration of solid tumors like the cystic neuroendocrine tumor or cystic ductal adenocarcinoma, acne cell cyst adenomas, cystic teratomas, and benign non-epithelial lymphangioma and sarcoma are of non-epithelial origin. Now, what is the relative incidence of these? Overall majority of the cysts that we see in clinical practice are usually pseudocysts developing as a consequence of acute pancreatitis. Also, among the neoplastic cysts, more common are the IPMNs and mucinous cystic neoplasms and serous cyst adenomas. Others constitute a very small percentage of the cystic lesions that we see in clinical practice. So, for the purpose of today's discussion, I will restrict my talk primarily to the neoplastic ones, which is IPM and MCN, serous cyst adenomas, SPEN, and cystic neuroendocrine tumor, and the non-neoplastic ones, pseudocysts, which we see very commonly. So I'll go briefly into the morphology and presentation of each. If you look at a pseudocyst, the pseudocyst usually develops as a consequence of acute pancreatitis or an acute on chronic pancreatitis, not otherwise. And this can happen at any age. Sorry for the typo, they should be mucinous pseudocyst here. The extrapancreatic wall contains fibrous or granulation tissue, well circumscribed, dark, rich fluid. The fluid is very dark, rich in pancreatic enzymes. Usually, you'll see a communication with the pancreatic duct and intervention only if the patient is symptomatic. However, the risk of malignancy in this are very, very low. Now, what is a serous cyst adenoma? Serous cyst adenomas are, on the other hand, are neoplastic cysts. They usually have an irregular nature. They're composed of both microcysts, small cysts, as you can see here in the gross specimen, and macrocystic features. They're lined by cuboidal epithelial cells and have this small microcyst within the lesion. Now, most of the serous cyst adenomas usually present in the 4th to 6th decade of life. 75% of them are usually in females. They can be located anywhere in the pancreas, like head, body, or tail. And one interesting feature of serous cyst adenoma is that 30% of them have central calcification. The internal structure consists of microcysts, which are small cysts, or they are larger cysts, and they sometimes have a very honeycomb pattern. There is no communication with the main pancreatic duct in a serous cyst adenoma. The external contour, as I discussed earlier, was lobulated, as you can see in this case itself. They do not contain mucin. Most of them are usually asymptomatic and may present with a mass lesion, and risk of malignancy in this group is nil. Now, what about mucinous cystic neoplasms? Mucinous cystic neoplasms are more commonly encountered in clinical practice, and as you can see, they're well defined, can be unilocular or have a septae in between. On gross specimens, they can be unilocular or sometimes even multilocular with septae in between. And they are lined by columnar epithelial cells, which are placed with mildly atypia and a hypercellular subepithelial stroma. Now, what about MCNs? MCNs include 20% of surgically resected cystic lesions. So they are pretty common, and they usually occur in the 4th to 6th decade of life. The MCNs predominantly contain ovarian stroma, and therefore these lesions are seen predominantly only in females, with the female to male ratio of 20:1. They occur in the body and tail of the pancreas. Even in MCN, you can see calcification, but they are more towards the wall of the cyst, which is called a curvilinear calcification. Internal structure is like a cyst within a cyst. MPD communication is not there. They contain dense mucin. Now, if you look at the risk of malignancy, for less than 3 centimeters, the risk is only 5%. However, lesions more than 3 centimeters, the risk is high. Some of them are asymptomatic and they present with pain, mass, or recurrent pancreatitis. Now, IPMN. This is the other group of mucinous neoplasms, and they are of three different variants. One which happen only in the main duct, or called the main duct IPM, ones which are in the side branch or branch duct IPMNs, and those which have a combination of both main and branch duct IPMN. Now, this is one postoperative specimen. This, as you can see, there are multiple proliferative lesions within the duct, a dilated duct with thick mucin. Histologically, they can be of four types: gastric type, intestinal type, pancreatobiliary type, or oncocytic type. Now, main duct IPMN usually occurs in the 4 to 6 decades and they have an equal sex predominance. These lesions have been predominant the head of the body, head of the pancreas. Now, the most interesting is that you can see as a diffuse or segmental dilatation of MPD. But most importantly, there is no stricturing. So if you see a segmental dilatation of the main pancreatic duct or diffuse dilatation of main pancreatic without an obstructing calcification or stricture, please consider IPMN. The internal structure is like grape-like that we showed in the gross specimen. The main pancreatic duct communication is present in them. They can be multifocal. That means they can be in the head, and also some foci can also be in the body tail region. And they have mucin. The risk of malignancy in this group is very high, and they present usually with recurrent pancreatitis, back pain, weight loss, or diabetes mellitus. The other variant is branch duct IPMNs, which are these usually occur in the 4 to 6 decade of life and have equal sex distribution. Again, these also in the head. They usually present with a dilatation of a side branch of the pancreatic duct. The internal structure is similar to that of a main duct IPMN, and communication with the main duct exists. This can also be multifocal and have mucin. The risk of malignancy in branch duct IPMN is much lower than that of a main duct IPMN. Now, this other variant, which has both brain and branch duct variants, their risk of malignancy is similar to that of a main duct IPMN and should be treated as a main duct IPMN. The other lesion that we would like to discuss here is the solid pseudo-papillary epithelial neoplasm, which is also called a SPIN. This consists of an encapsulated solid cystic mass. So it is predominantly a solid mass with cystic areas which generate basically because of hemorrhage within the lesion. As you can see, there's a distinct hemorrhage. They consist of poorly cohesive cells which detach and arrange radially to form a pseudopapilla. Now, SPIN occurs usually in a younger age group between 22nd to 3rd decades. Women are most often affected with SPIN. They occur in the body tail region, and the internal structure is predominantly of a solid cystic, more solid, and of a dense fibrous capsule. They do not communicate with the main pancreatic duct, and they are usually solitary. They have a low risk of malignancy. Most of the patients with SPIN younger women who come with SPIN present usually with a pain abdomen and an incidentally detected lesion. The cystic degeneration of solid tumors, predominantly the cystic pancreatic neuroendocrine tumors, it consists of almost 15% of all the peanuts that we see. And this usually occurs in the 6th decade, again in the body tail region of the pancreas. So one interesting thing about cystic pancreatic neuroendocrine that they have a very good blood supply, and therefore the most important feature that we look for is the peripheral rim enhancement, as you can see here. So it's a thin rim of enhancement that you can see around the cystic lesion, which should raise the concern that we are dealing with a cystic pancreatic neuroendocrine tumor. The internal structure is more solid than cystic, and the MPD communication or mucin production does not exist. If you look at the risk of malignancy, there definitely has a high risk of malignancy, but it's much lower than that of solid neuroendocrine tumor. Most of the patients are asymptomatic. Rarely they can present with recurrent pancreatitis. So WHO has classified this pancreatic cystic neoplasms into three major categories: benign, borderline malignant, and malignant. And why it's important to know is for benign lesions, you do not need surgery, you do not need surveillance. Borderline lesions require surveillance, whereas malignant lesions require surgery. Serous cystic neoplasms can be grouped into two groups: serous cyst adenoma, serous cyst adenocarcinoma. Adenocarcinoma is malignant and therefore requires surgery, whereas benign lesions do not require any follow-up or surgery. Mucinous cystic neoplasm are again into three grades: mucinous cyst adenoma, mucinous cystic neoplasm, cyst adenocarcinoma. And the MCN primarily is the one which is classified into, again, low-grade dysplasia, high-grade dysplasia. And these are classified as borderline neoplasms and may be considered for surveillance or surgery depending on the clinical context. Mucinous cyst adenocarcinoma should be considered for surgery if the patient is stable. IPMNs can be classified as low-grade and high-grade, and low-grade are usually borderline type. High-grade is carcinoma in situ, and they can be put up for surveillance. But whenever there is an invasive carcinoma or malignancy, one should consider surgery followed by post-operative surveillance. Similarly, for SPEN, because they're symptomatic, many of them are offered surgery, and SPEN can be borderline or pseudopapillary carcinoma, which is malignant. So now I'll come briefly to the diagnosis of pancreatic cystic lesions. Now, there are certain challenges with the diagnosis of pancreatic cystic lesion. This include primarily the lesions are heterogeneous, there are variable symptoms, or patient may be asymptomatic and the lesion is detected incidentally. There's the evolving nature of the disease. The patient can progress from benign to borderline malignant to malignant and therefore require surveillance. There are limitations in the imaging that we'll discuss shortly, that we may not have a thorough imaging thing. There are challenges with cytological analysis and molecular diagnosis. And of course, multiple societies have put up guidelines, and there's a significant variability in the guidelines. So, what are the goals of evaluation? The goals of evaluation is primarily to discriminate between benign, borderline, malignant, and malignant. The idea is to not to offer surgery to patients who are benign, because that would increase the risk and morbidities. So, benign lesions like pseudocyst or serous cyst adenomas do not require any surveillance. However, borderline lesions like mucinous cystic neoplasm or IPMN require surveillance or surgery. And malignant lesions like where there is cancer, invasive cancer, require surgery. And the goal of evaluation is primarily to discriminate between these three entities, because that would determine our treatment strategy. Now, how to go around this diagnosis? The steps is to first assess the symptoms. If the patient is overtly symptomatic, then we know we are dealing with a dangerous lesion. If rule out that that's what we're dealing with is not a pseudocyst, and it's very easy to rule out a pseudocyst. Usually there'll be history of abdominal pain, there'll be history of pancreatitis, there'll be or background history of chronic pancreatitis. And discriminate between mucinous versus non-mucinous, identify high-risk features, and determine the surveillance and treatment option. So we first start off with cross-sectional imaging, and there are certain elements of cross-sectional imaging which we should ensure must be reported. And this includes the cyst morphology and location, the cyst size. We know that cysts less than 10 millimeters harbor a low risk of malignancy and therefore do not require surgery or any form of surveillance. We should identify the relationship to the main pancreatic duct, presence of worrisome features or high-risk stigmata, multiplicity of the lesions, whether there's multiple lesions, and of course, growth on follow-up imaging. Amongst the imaging modalities, MRI and MRCP is the preferred modality. And MRI is preferred imaging modality because it has a high accuracy for identifying the specific type of pancreatic cystic neoplasm. It has got a superior soft tissue contrast resolution. Accuracy is 89% in detecting solid mural nodules. And low, but however, there's a problem with MRI. It cannot detect calcification, there are motion artifacts. And in certain situations, CT scan is required, especially if there's calcification, to determine whether you're dealing with parenchymal, mural, central calcification, and especially when you're trying to discriminate between a pancreatic pseudocyst from a pancreatic cystic neoplasm. Again, malignant pancreatic cystic neoplasm, we need a CT scan to determine the vascular involvement, the peritoneal involvement, and the risk of metastatic disease. And if there's a suspicion of postoperative recurrence, we prefer to do CT scan. So just to summarize on our table, what are the features on cross-sectional imaging? And I've highlighted red, which basically are the hallmarks of it. Now, if you look at location, most of the pancreatic cystic neoplasms can occur in the body tail or everywhere, except for IPMS, which are predominantly in the head and uncinate region of the pancreas. If you look at morphology, mucinous cystic neoplasm, as we discussed, are unilocular or macrocystic. IPMN have a cyst with mural nodules. Microcystic serous cyst adenomas are microcystic or can be macrocystic, whereas PEN and cystic degeneration neuroendocrine tumors are solid cystic. If you look at the risk MPD communication, then only IPMN and pseudocysts have communication with the main duct. The main duct size is normal in most circumstances, except for an IPMN, which can be dilated more than 5 millimeter, or in pseudocyst, where this duct may be dilated or may be irregular because in the setting of chronic pancreatitis. If you look at the cyst wall, the enhancement of the cyst wall is typically seen in cystic neuroendocrine tumor. And if you look at calcification, then only two of them have a calcification, and that also in two different sites. Mucinous cystic neoplasm have calcification in the wall, which are in the form of curvilinear calcification, and serous cysteinoma have central calcification, 30 to 40%. And multifocal nature of the disease, only IPMNs are multifocal. So, coming from cross-sectional imaging to endoscopy. If you look at endoscopy, then on the side being endoscopy, in IPMN, we can see sometimes mucus extruding out of the major papilla. And this is called the fish mouth papilla. This is seen almost in 50% of main duct IPMN. And once if you see this, it's almost a 91% specificity for diagnosis in main duct IPMN. And if you're doing it in EUS and you see this, you probably don't need to proceed further with an EUS. Large lesions can deform the B1 lesion, and occasionally they can be a fistula formation. But endoscopy beyond diagnosis of fish mouth papilla doesn't have much value in the diagnostic algorithm of cystic neoplasms. Therefore, we look at something more advanced than endoscopy, and that is endoscopic ultrasound. The primary purpose of endoscopic ultrasound is to delineate the cyst size, to characterize the cyst wall, identify septations and calcifications, look at mural nodules, relationship of the cyst with the adjacent organs, vasculature, communication with MPD, and measurement of MPD diameter. Now, different societies have given different guidelines of when to do EUS. Now, if you look at the IAP and the ACG guidelines, there are some commonalities. The commonalities include, if the cyst is more than 3 centimeters, you have an MPD which is more than 5 millimeter, or if there's an abrupt change in the caliber of MPD with an upstream atrophy, then definitely we should consider EUS. In addition to that, both those guidelines also mention two other things. That is, one is if there's presence of mural nodules or there's an elevated CA99. But the latest European 2018 guidelines are very simple, and they highlight that we should do EUS whenever the diagnosis is unclear and the results are expected to change the clinical management of the patient. However, if the diagnosis is clear and the patient is operable, then there's no point in doing an EUS and one should proceed with surgery straight on. So, how does morphology help us? If you look at the cyst wall properties, you look at calcification in the wall, then more likely you're dealing with mucinous cystic neoplasm. With the cyst characteristics, then serous cystinomas are microcystic or macrocystic pattern, but mucinous cystic neoplasm have oligocystic or usually oligocystic or have large cysts. If you look at the internal characterizations, we can look at the septa. At the thickened septa, there's a high risk for neoplasm, and you can consider mucinous cystic neoplasm. Presence of mural nodules, which highlight either in IPMN or MCM. Solid component, if you see, then more likely you're dealing with a cystic neuroendocrine tumor, SPEN, or a malignant variant of IPMN and MCM. If you look at for communication with the pancreatic duct, then only two of them communicate, that is IPMN and cirrhosis. And if you look at associated cystic masses, you can consider either cystic neuroendocrine tumor, and very rarely, sometimes the pancreatic ductal adenocarcinoma also necrosis and produces a cystic appearance. So, what are the features of malignancy at EUS? The features of malignancy at EUS include a large cyst, more than 3 centimeters, presence of mural nodules, more than 5 millimeters. If there's septal thickness, if the thickened septa more than 2.5 millimeter, one should consider a possibility of malignancy. If there's a cyst producing a bile duct obstruction or a dilated MPD, one should consider malignancy in the patient. And if you so the one thing that we've been talking now for the last couple of slides have been mural nodules. Now, what are mural nodules? Mural nodules are formed in the wall of the cystic neoplasm, predominantly seen in IPMN in the form of a thickening of the wall or a form bleb. Now, the problem with mural nodules is that sometimes, even in IPM, which secretes so much amount of mucin, that it's very difficult to discriminate between inspissated mucin and mural nodule. EUS helps in certain extent because in EUS, if you look at the echogenicity, then mural nodules have a hyperechoic, hyperechoic with irregular margin, whereas mucinous lesions are usually hypoechoic and have a hyperechoic ring. But these are very subjective and maybe sometimes difficult to discern. Then comes in the role of an advanced modality of EUS called the contrast harmonic EUS. The contrast harmonic EUS, as you can see in the right upper quadrant, going on for another cystic neoplasm with small microcystic patterns, it involves injection of an IV contrast, which is Sonoview, which is an ultrasound contrast. Now, once we inject the IV contrast, within 25 to 30 seconds, you can see an enhancement of the vascularity. And this is in pancreatic cystic neoplasm. Its primary role is in discriminating neural nodule from mucin and nothing beyond it. As you can see, this is all taking a vascular area, so this is probably not mucus, more likely to doing with a nodule out there and presence of a, should consider FNA. Now, if you look at it, the full sensitivity of contrast harmonic EUS to discriminate between neural nodule from mucin has been to the tune of 97%, and specificity is 90%. As in this case, you can see there's a small blob here, which possibly is a neural nodule, but on contrast harmonic, it does not take up any contrast, and so this is more likely to be a mucin plug. Then, of course, EUS gives us the opportunity of puncturing the cyst, aspirating the content, and assessing the content. And in the content that we are primarily concerned about is to discriminate between mucinous and non-mucinous. And a very simple way to discriminate between mucinous and mucinous is a string test. The string test involves either taking 2 slides, putting a drop of the aspirate into 2 slides and separating the slide, or putting it between 2 gloved hands and separating it out. Now, if you see a string of more than 1 centimeter of length, which stands for more than 1 second, then this is a positive string test. And the sensitivity of this to identify mucinous lesions is 58%, but the specificity is 95%. So this is a very specific test to identify, viscous, aspirate, and diagnose mucinous cystic lesion. Once we aspirate the content, we can send for multiple analysis, and one of the analysis that we commonly do is the carcinoembryonic antigen, or CEA. Now, there has been no well-defined cutoff, but however, we know that if CA is more than 192, it very well discriminates between mucinous from non-mucinous. And sensitivity of this is 75%, specificity is 84%. CA less than 5 nanograms per ml, you definitely know this is not a mucinous lesion. And CA more than 800 is definitely mucinous. So the range of CA is very wide. From 192 to 800, it can be anywhere. And anything more than 182, one should suspect that we're dealing probably with a mucinous lesion. A more easy way to determine a mucinous lesion is to look at the glucose content of the fluid aspirate. And this can be done in the endoscopy room itself with a simple glucometer. If the intracystic glucose is less than 50 milligram per deciliter, then it discriminates between mucinous and non-mucinous. And this performs better than CA of 192. A meta-analysis of 36 studies show that glucose perform better than CA and a higher sensitivity than CA in discriminating mucinous from non-mucinous lesions. So mucinous lesions have very low intracystic glucose. What about molecular markers? These are the ones that are used, and I'll discuss the other ones a bit later. Now, within the cyst, now we have next generation sequencing available, and we can look for oncogenes within the cyst, and these include the GNAS and the KRAS. And a meta-analysis of 6 studies have shown that GNAS and KRAS have a high sensitivity for diagnosing IPMN and a specificity as well an accuracy of 97%. Whereas GNAS and KRAS can also discriminate mucinous cystic lesions, and the sensitivity is same as CEA, but the accuracy is higher. So definitely GNAS and KRAS, if we look at it, it has a very high sensitivity specificity for diagnosing IPMN. If you're inside the cyst, we can always aspirate the content and examine for cytology. The problem with cytology is that the aspiration is usually a paucicellular, and therefore, to get a correct diagnosis sometimes is difficult. The sensitivity of specificity of aspirated fluid is 54% and 93% respectively. So it is definitely a poorly sensitive test, but if you have good cytology, then you can easily diagnose even solid pseudopapillary tumors or a neuroendocrine tumor. Now, an addition to this has been the use of through-the-needle biopsy forceps. Now, through-the-needle biopsy forceps can be used to biopsy either the septa, the neural nodule, to increase the sensitivity. Now, it is done by passing a forceps through a 19-gauge needle into the pseudocyst. into the cystic lesion, and either biopsying the neural nodule or the septum. The diagnostic accuracy of this technique is 78%, sensitivity is 80%, and specificity is 97%. And a mean of three passes is required to improve the accuracy. However, this has come in with risk factors, including bleeding from the cyst wall as well as from the form of pancreatitis. So at EUS, how can we discriminate different lesions? So again, I'm not going into the details of morphology and ductal communication, but I'll just go into the viscosity. IPMN, MCN are predominantly viscous lesion. In serous cystadenoma, you get a thin cloud lesion. So solid pseudopapillary tumors usually get bloody. In cystic neuroendocrine tumors, the viscosity is variable, and cirrhosis, the viscosity is very, very thin. Most of the lesions, the aspirate is generally clear, except for serous cystadenoma, which is occasionally bloody, and in solid pseudopapillary tumors, which can be bloody. The cyst fluid amylase is something we use, and in IPMN, the cyst fluid amylase can be high because of the ductal communication, and in cirrhosis, obviously, it is high. But in all other circumstances, cyst fluid amylase is low. Ca is elevated in mucinous lesions and low in non-mucinous lesions, and the high is more than 192 nanograms per ml. Cyst glucose is lower in mucinous lesions like IPMN and MCN. And molecular markers like KRAS and GNAS adequately identify IPMN and KRAS for MCN. I'll talk about this a bit later, what the other molecular markers that we can use include the VHL and the CTNNB1. So now, as we discussed in the quiz, so we decided to do the EUS of this lesion, and EUS showed a large unilocular cyst with a thick content. It was large, well-defined, 8 to 7 centimeters. The fluid was mucinous, string test was positive. The glucose content within the cyst was 16 milligrams per deciliter, and the CEA was 10,271 nanograms per ml. So I think we had 100% diagnosis of MCN, and this particular case underwent a distal pancreatectomy and a splenectomy, and that showed a mucinous cystic neoplasm with a low-grade dysplasia. So I'll come to the newer diagnostic tools which can improve the diagnosis. And
can we take the break and can take the question if Dr. Matthew Philip is also agreed?
Sure. Please do.
This.
How many more slides on diagnostic tools?
I think we have around 5, all these four slides, sir.
I think, after diagnosis, we can take up the questions.
Okay.
Rajesh, is that fine?
Yes, sir.
Shall I proceed?
Yeah, you proceed. After 5 minutes, we will take up the questions.
Yeah. So the newer diagnostic tools that we have include confocal laser microscopy, advanced molecular markers, artificial intelligence, and I'll briefly touch upon the role of pancreatoscopy here. Now, confocal laser endomicroscopy is a new modality. It has been in focus for a long time now. However, because of cost constraints and imaging limitations, this has not gained that much popularity. The technique involves administration of a contrast solution consisting of fluorescent dye, fluorescent sodium intravenously, and a probe is inserted through the 19-gauge needle into the cystic lesion. And as you can see on the left side, this is a superficial vascular network. As you can see, serous cystadenoma is quite pathognomonic of serous cystadenoma. And even in IPMN, without having to do much aspiration, I think you can diagnose papillary projections in the IPMN. So it's an additional to significant cost constraints that has limited its widespread use. Now, as we discussed the molecular markers, recent advances in molecular marker and next-gen generation sequencing has even enabled us to do further markers, and one of these markers is VHL gene mutations. A VHL gene mutation is predominantly seen in serous cystadenoma, and the sensitivity of this is 71%, specificity is 100%. The other one is MEN1 and the loss of heterozygosity genes. This can be seen predominantly in PNET with a sensitivity of 68% and specificity of 98%. And the cyst fluid can be sent for these molecular markers. The more interesting one is this 4 combination, EP53, MAT4, CTNNB1, and mTOR. Now, we know the GNAS mutation helps us identify IPMN as we discussed in the previous slide. When you combine GNAS mutation and this score in a panel itself, the sensitivity of identifying advanced neoplasia rises to 88% and specificity is 98%. So just addition of these four molecular markers to the GNAS significantly improve the sensitivity and specificity. So as the time evolves, we'll have more and more markers coming in for cystoid analysis, and this is a very exciting field now. Of course, now artificial intelligence has come in, and since 2019, artificial intelligence has been used in the evaluation of pancreatic diseases. And AI can help stratify pancreatic cystic lesions, differentiate between different types of pancreatic cystic lesions. There are different models of AI include deep learning, and including this is a retrospective study of 50 IPMNs with a malignancy in 23 patients. Deep learning algorithm was used to analyze 3,790 EUS images. Interesting thing is that with the deep learning algorithm, the accuracy of diagnosis and malignancy was 94%. However, on the human side, the accuracy was 68%, even when the presence of mural nodule is there. So AI is going to come in shortly in a great way, and as it becomes more readily available, it will be a useful tool in the diagnosis and evaluation of pancreatic cystic lesion. I'll just go briefly into another interesting area, which is the spyglass cholangioscopy. Now, spyglass cholangioscopy, as you all know, has been used routinely for assessment of the bile duct. In the pancreas, when we assess it, it has been used for intrapancreatoscopy. Now, as we discussed earlier also, the IPMNs can be multifocal, and therefore in IPMN, it is important to understand the extent of the disease and to identify stick lesion. So, as you can see in this is a spyglass image of an IPMN. You can see this nice grape-like clusters on the wall of the cyst and in the wall of the duct, and this is the duct lumen here. Now, the extent to which intrapancreatoscopy altered diagnosis is to the extent of 13 to 62%, and also helped in decision making whether the patient goes for only a Whipple's or a total pancreatectomy. The features of malignancy include if you see a coarse mucosa, friable mucosa, tumor vessels. But this comes up with complications, and the risk of complications of pancreatitis is to the tune of 10%, which is fairly high. So we can stop here.
Dr. Rajesh, can you please take up the questions? And I request all the people who are listening to it to put your questions in the chat box. We will try to answer all. And after 10 minutes, we will restart the meeting and we'll continue with the treatment. Dr. Rajesh, please.
Thank you, Dr. Sudipta, for the excellent overview of how to approach the cystic lesion of the pancreas. And if I look at the chat box, there's a question from Dr. Matthew Philip. There are situations where one can have multiple cysts in the pancreas, like associated with the polycystic disease, von Hippel-Lindau syndrome. What are those cysts? Should we intervene those cysts? How to evaluate those patients?
Okay. That's a very interesting question, actually. And in VHL, as you know, the whole pancreas can be replaced by multiple cysts. Most often than not, these cysts are usually simple cysts, and even when they progress, they would be a serous cyst adenoma. Likelihood of that having any other altered malignant cyst is unlikely. However, there is a small percentage of patients with VHL who can develop neuroendocrine tumors, solid neuroendocrine tumors of the pancreas, and therefore the surveillance is indicated. Otherwise, for routine cysts that we see in VHL, we do not require routine surveillance of these because they are just simple cysts of the pancreas.
Okay. And the next question is from Dr. Harsha. How to manage a cystic lesion which is less than 2 centimeters?
Okay. I'll just come to the diagnostic algorithm as we come further. Is that okay, Dr.?
I think
because we can discuss this in the next slide itself. That will be helpful.
Another very pertaining question. In India, we have a potential to have a parasitic cystic in the lesion in the pancreas, like hydrated cyst. So how do you differentiate that this is a parasitic hydrated cyst or it is a cystic neoplasm of the pancreas?
That's a very interesting question. I haven't clinically found many such patients, but we do hear of occasional that you can see parasitic cyst. The most of the parasitic cysts, when we do an EUS, are usually anechoic for the major part, or you can see floating membranes within the cyst. And so that's what you'll see: floating membranes, daughter cyst, and you do not see septae, you do not see neural nodules.
Okay, so the next question is by Dr. Lal Krishna. The management strategy of IPMN, which guidelines I think you are going to cover, so we can wait for
We're
this
going to
question.
come that on that.
And Dr. Nanda Kumar, what are the chances of pancreatic main IPMN communicating also with the biliary duct? How frequently it is seen?
Um,
So main,
well,
main duct,
I,
what are the chances of communication with the main bile duct? How frequently it is seen?
we have seen a fair number of IPMNs even in our own personal series in the hospital, and we haven't seen many induct IPMNs communicating with the bile duct, except when there's a large cyst and it forms a fistulizing communication to the into the duodenum. And I would say it's very infrequent, but I do not know the exact number.
Okay,
Rajesh,
Dr.
you might give some.
Yeah,
I'm
Dr.
not seeing.
Sudipta, I have two questions which will be very relevant in the day-to-day clinical practice. We have discussed MRI, we have discussed CT scan, we have done endoscopic ultrasound, and so many tests in endoscopic ultrasound, right from glucose to CEA to the molecular markers, now the advanced molecular marker, and we have done the Boris 5 biopsy forceps, and there is a microscopic examination. So this, all these tests make a lot of money involved in this.
Absolutely.
A very simple question. Any patient who comes to you with a cystic lesion of the pancreas, what is the best clinical strategy to give a reasonably good answer to the patient? Because in spite of doing all tests, the accuracy doesn't goes more than 70 to 80%. Still 20% of the patient we don't know. So which is the, in Indian scenario where the cost is a constraint, which all tests you will recommend to the patient? Number one, which test you are going to recommend, when you are going to recommend, when you tell the patient there is no need to do anything, because a patient who has an advanced 90-year patient who has an advanced cystic lesion, then there's no point in doing the surveillance. So I want to know a brief message from you, how to investigate and up to what level you are going to investigate these patients.
So I'll put it very simply, Dr. Rajesh. If a cyst is less than 10 millimeters, one does not need to do anything in this group of individuals. And the best imaging model.
Can I ask one question? The main duct IPMN of 10 millimeter.
No, I'm not. I'm talking about cyst. I'm not talking of the main duct. I'm talking about cyst per se. Of course, question was pertaining to the cyst per se. So I'm talking about a main duct IPMN is a different story altogether. Because at 10 millimeters, you're worried about malignancy. But I'm talking about in any other circumstances, when you come across an incidentally detected cyst in the pancreas, if the patient has a history of pancreatitis, more likely we're dealing with a pseudocyst. And if the patient is asymptomatic, you do not need to do anything in this group of individuals. If the patient has a cyst which is less than 10 millimeters, diagnosed on cross-section, good quality cross-section imaging like an MRI, there's no other solid lesions anywhere, then we do not need to do anything in this group of patients. That solves the problem. The problem per se lies in two factors: cysts which are between 1 to 4 centimeters and beyond 4 centimeters. As we say, in cysts which are more than 4 centimeters, I'll come to the diagnostic algorithm when I'm talking this, is that when you're talking to cysts more than 4 centimeters, you're dealing with probably a neoplastic cyst, and that needs to be examined more thoroughly and determined whether you're dealing with a mucinous, non-mucinous, or if there's a malignant potential to it. Between the 1 to 4 centimeters is where there's a lot of variability as to whether one should do an EUS, should do an MRI, and what the surveillance interval is. So I'll touch upon those areas briefly, Dr. Rajesh, in the next few slides, if that's okay with you.
Okay. Now, a few more questions, because in the era of endoscopic ultrasound, everybody is doing the endoscopic ultrasound, and when they find a cyst, they puncture the cyst. What is your message to the young generation when you are doing it? First of all, will you do endoscopic ultrasound in all cysts? If you are doing endoscopic ultrasound, will you puncture all cysts? And when you are puncturing, what precautions you are going to take? If you can guide the youngster about this.
So I'll put it very simply, Mr. Rajesh. EUS is not required for all cystic lesions of the pancreas. That's number one. Let's take it further. EUS is required only when the intervention is going to change the management of that individual, especially an EUS FNAC, because it comes with the caveat risk of leakage, pancreatitis, cyst infection. So one should be very careful once before we puncture a cyst. Just a random puncture is not necessary. A good quality MRCP gives enough information as to determine the nature of the cyst. So, even if you ask me where I will do it and where I will not do it, I will not do it if the patient is not fit for surgery, not planned for any therapy, or the cyst is determined to be and the operative. However, I will inside of the cyst. There is a cyst which is more than 3 centimeters. MRI shows possibility there are septations, the thickened septation. Definitely, I will go in and assist with the EUS.
Okay, Dr. Sudipta, the question from Dr. Naveen Mehla. What is the role of CA 19.9 in the cyst fluid for diagnosis of malignancy? Does it has any role?
No, no role.
Okay. Another question from my side. When you aspirate the fluid and you only aspirate 1 ml of the fluid, which test you would suggest that give the best information about the cystic lesion?
Don't need to do anything. Just take the needle, put it to your glucometer next, which is available in the room, and get this glucose test. That will clinch the diagnosis in 90% of the patients.
Absolutely right. Now, there's another question from Dr. Karan. When to suspect other differential other than pseudocyst for cystic lesion with a history of recurrent acute pancreatitis? Meaning that patient has a history of recurrent acute pancreatitis. When do you feel that this is not pseudocyst, this is a cystic lesion of the pancreas? Good question.
I think this is a very relevant question, and that's primarily if anyone who comes in with a recurrent acute pancreatitis beyond the fifth decade of life, please look for a neoplastic source. And if there's a cystic lesion in a person with a elderly person with recurrent acute pancreatitis, I would definitely assess the cyst for a mucinous cystic lesion or for a IPMN.
The question from Dr. S.K. Sharma from New Delhi. What is the prevalence of regional lymphadenopathy in IPCN? IPMN होना चाहिए. Is there any role of PET scan in suspected malignant lesion? Do you do advise scan?
No, we do not do PET. FDG PET uptake of cystic lesions have been very poor, and therefore I did not bring it into discussion. The prevalence of regional lymphadenopathy in IPCNs, I am probably not aware of the exact number, so I may not be able to quote a number on that. But if there is regional lymphadenopathy, then we are suspecting a malignant transformation, and that patient should be offered surgery.
And the question is another question from Dr. Sivesh Thakur from Indore. What is the median time to develop pre-malignant to malignant lesion in various pre-malignant cystic lesion?
I think it's very important question. Yeah. It's important in the sense that will give you the timeline and understand why the guidelines are coming as such. The risk of malignant transformation is within the first 2 years of the diagnosis of the cystic lesion. After 3 years, if the cyst has not progressed, then unlikely the cyst is going to progress ever, and therefore the risk comes down. So therefore, the surveillance recommendation that we'll talk about shortly from ECG also clearly says that you should do evaluation only for the first 3 years since the cyst has been diagnosed.
Dr. Matthew, we have a time to discuss questions, or we should start?
No. I think we should resume for the talk now. We'll take the questions at the end. So I think we'll start the presentation now.
Can I just start, sir?
Yeah.
Yes.
Thank you. Sorry. So now that we have a cyst, we have to discriminate between those cysts which have a high-risk stigmata and those which have features which are worrisome. Now, high-risk stigmata include when you have an enhancing neural nodule of more than 5 millimeter, we have obstructive jaundice because of the cyst in the head of pancreas, that is, the cyst is occluding the duct, or the MPD is more than 10 millimeters. These are features of high-risk stigmata. But there are features which should one make us worried that we are dealing with a malignant cystic neoplasm. And if the cyst is more than 3 centimeters, again, if they're in mural nodules, but they're small mural nodules, MPD caliber is between 5 to 9 millimeters. If there's an abrupt change in the MPD caliber with a distal atrophy of the gland, one should consider a IPMN possibility there. If there's a thickened cyst, if the IPMN rapidly is growing over the 2 years of follow-up, as discussed earlier, one should consider a worrisome feature. The blood CA99 has been used by certain guidelines, and I leave it here because that has not been particularly helpful. But most of the guidelines, some of the guidelines actually recommend that looking at CA99, and the CA19 is more than 37, that one should consider this as a worrisome feature and evaluate the cyst more extensively. And of course, as we discussed, lymphadenopathy is a worrisome feature. Now, the multiple guidelines. For the purpose of the talk, I've just restricted to 2 major guidelines, and these include the IAP guideline of 2017 or the International Consensus Guidelines and the European Guidelines of 2018. Now, if there's an absolute indication for treating a patient in IAP guidelines, is an NPD more than 10 millimeters, if the enantic neural nodules, jaundice, or a solid mass, as in the high-risk feature. Similarly, the European more than 10 millimeters is a positive sign to treat, definitely. However, there is a variability in when there's a relative indication for surgery. The relative indications include when there's a growth at 5 millimeters per year, if the cyst has more than 3 centimeters, if there's a background history of acute pancreatitis, thickened enhancing wall lymphadenopathy, or abrupt change in MPD caliber, as was the original worrisome features. So these are relative indications for treatment. So what is the treatment options in pancreatic cystic neoplasms? For lesions in the head of the gland, most of the surgeons prefer to offer a Whipple's procedure. Those in the tail of the gland undergo distal pancreatectomy. Occasionally, we have IPMNs which are multifocal or have a diffusely dilated duct right up to the tail, and these patients undergo a total pancreatectomy. Now, I'm not going into the surgical details of this, because this is beyond the scope of this talk. So I'm going to touch briefly on the endoscopic options that are available for therapy. And one of the endoscopic options for therapy is called the EUS guided cyst ablation. The EUS guided cyst ablation can be done using absolute alcohol combined with paclitaxel or radiofrequency ablation, which is a heat ablation. The primary indications for this are the cyst should be a benign cyst of maximum 2 to 4 centimeters, unilocular, oligolocular, and there should not be any communication with the main pancreatic duct. Because if you inject alcohol and there's an MPD communication, high risk the patient will develop pancreatitis. The problem, the success rate of this has been with ethanol and paclitaxel has been the highest to the tune of 70%, ethanol alone 32%, but RFA has had a poor success rate. The adverse events in this procedure is high to the tune of 14%, and the more common ones include pancreatitis, intracystic bleeding, ductal leak, and fever. So this is still an area of active investigation and not currently considered a current standard of care. So once a patient undergoes operation, how do we follow up this patient? Now, if the operation shows evidence of invasive cancer or high-grade dysplasia or IPMN, then we need a MRI at 2 yearly intervals. If there is no such feature, but we look for a family history of cancer. If there's a family history of cancer, we need MRI at 2 yearly interval. However, if there is no family history of cancer, then the patient does not require any further surveillance. Now, I'll touch briefly on the surveillance of pancreatic cystic lesions and why we discussed this earlier as to how we go about surveillance. Now, there are different guidelines that put up different algorithms for surveillance, and therefore it's important to understand where they are coming from. The ACG guideline of 2018 clearly states that for lesions which are 1 to 2 centimeters in size, we can do an MRI at 1 year interval for 2 years, and then MRI every 2 years. For lesions of 2 to 4 centimeters, if MRI at the rate 6 monthly, for 3 years, MRI EUS at 6 monthly for 3 years, followed by MRI or EUS at 1 year interval for additional 3. So the As discussed in the question earlier also, the highest risk of malignancy is in the first 3 years of follow-up, and therefore the intensity of follow-up is also higher during this period. The European guidelines slightly differ, and they are very simplistic to follow, that any cyst which is more than 4 centimeters, we should operate the cyst. A cyst of 1 to 4 centimeters require, in the first year, we can do MRI or EUS at 6-month interval along with CA99. And if the cyst does not progress, then after that it is at 1 year interval for the next 4 years. So now I'll just give briefly the treatment algorithm that we follow at CMC, and this may not be generalizable elsewhere. So if we detect an incidental cystic neoplasm, what we ask for is a history of pancreatitis. If there's a history of pancreatitis, we evaluate for a pseudocyst. If there's no history of pancreatitis, we assess this, and the patient is very, very overtly symptomatic, then there are two possibilities. If the patient is symptomatic, then the patient should be offered surgery. If the patient is not symptomatic and there are presence of high-risk features like an enhancing nodule duct more than 10 millimeters, then also the patient should be offered surgery. However, if there is no high-risk features, no enhancing nodule, or duct is less than 10 millimeters, but we look for worrisome features. The worrisome features include cyst more than 3 centimeters, thickened duct wall, NPD of 5 to 9 millimeters, non-enhancing nodule, an abrupt change in pancreatic duct diameter with distal atrophy. In this, if it is there, then we offer EUS, and we follow the European guidelines of 6 monthly and then yearly. If no, then the patient is offered for surveillance. So just to summarize, pancreatic cystic lesions are common. Not all of them harbor malignancy, and therefore risk of malignancy is relatively low. MRI is a recommended imaging modality for pancreatic cystic neoplasm. EUS should be considered only when diagnosis is unclear and the results will alter the management of the patient. Surgery should be considered when the high-risk features, and surveillance is recommended for cysts of more than 1 centimeter.
Thank you, Dr. Sudipta, for the excellent lecture and giving the overview, both diagnosis as well as treatment. Now, I think we can discuss about the questions in the chat box. Yeah. So, there is a question from Dr. Lal Krishna. Management strategy for IPMN, which guidelines have to follow?
So as we discussed earlier also, these guidelines have been a bit of a controversy because there are multiple guidelines and things. For us, we follow the European guidelines, which are very, very straightforward. If the duct is dilated more than 10 millimeters, if the high-risk feature, patient should be offered surgery. Otherwise, patient can be followed up as per the size and interval recommended.
Okay, so there's a how's TB prevalence as a pancreatic cyst?
Very interesting question, because we know that now we see a few of the pancreatic lesions with pancreatic tuberculosis. And most of the cysts that we see in relationship to the acute with the pancreas have been lymph nodes which are centrally necrosed rather than the pancreatic TB per se. So I actually would not know the exact prevalence of TB with cystic lesions, but however, whatever cysts we have seen in our clinical practice in the setting of TB and pancreas have been lymph nodes which have necrosed centrally.
So just to add
Dr.
on,
Rajesh, if you have any comments on that.
Yeah. So just to add with Dr. Sudipta, this is very absolutely true. Majority of these patients have lymph nodal mass at the peripancreatic lesion. But I have published a paper of, I think, 18 cases of pancreatic mass lesion. A young guy presented with a fever, and there's a mass in the head of the pancreas. On CT scan, there was a suspicion of malignancy, and when you do an endoscopic ultrasound, it is a solid cystic lesion. So that is one of the presentation of the TB of the pancreas. And another question from Dr. Matthew Philip. precautions for cyst aspiration, FNB in the cystic degeneration of the NET. What is your viewpoint, Dr. Sudipta?
Okay, I'll divide the question into two halves, if you permit. One is the precaution of any cyst when you're doing an FNAC. Before 2020, we were all giving IV antibiotics for doing any FNACs of pancreatic cystic lesions. Since then, there has been a publication from Dr. Sham's group who showed that IV antibiotics are primarily not very helpful in preventing infections in pancreatic cystic lesions, and the risk of infections are very low. However, we are working in India where many of the centers do reuse the FNA needles. So if there's a history of FNA reuse, then you better to give antibiotics. Otherwise, we probably, in our center, for example, we do not reuse them. So therefore, we do not use IV antibiotics for cystic lesions. That's one. Now, neuroendocrine tumors are a different ballgame altogether. One, they are extremely vascular. Risk of bleeding is very high. And therefore, many times we would try to avoid FNAB of a neuroendocrine tumor. The thing with the neuroendocrine tumor, many a times, in fact, actually, we should have this, which is of course beyond the scope of the discussion. Contrast harmonic EUS gives a better delineation of the neuroendocrine and the vascularity within, and that is quite helpful in diagnosis without having to puncture with the needle per se. So in our center, we preferably try to avoid FNACs of neuroendocrine tumors, especially which have got high amount of vascularity.
Dr. Sudipta, another technical questions. Suppose a patient has a 3 cyst in the pancreas. One large cyst which has a 3 cyst in the pancreas, that's number one. Which cyst you are going to puncture? Number second, patient has a mural nodule and the fluid. Which first you are going to target? First you are going to target the mural nodule, or you are going to aspirate the fluid and then you are going to target the mural nodule?
So the two things, if there's a very large cyst and reaching the mural nodule is in a distance from us, then definitely we will aspirate the cyst, reduce the content, and then try to target the mural nodule. However, the cyst is small and if the mural nodule is clearly visible, we target the mural nodule before we aspirate the cyst content, because that gives us the margin of compression and risk of bleeding. That's what the protocol we follow. The other thing is about 3 different cysts in the pancreas, we target the larger cyst.
Okay. Another question from Dr. Shekhar Swaroop. Does this worrisome and the high-risk features applies to any cystic lesion or only for IPMN?
Primarily for IPMN.
And one more addition, it is also for the MCN also.
MCN. But primarily, these guidelines have been mainly made for keeping IPMN in view.
Yeah. And another question from Dr. Sneha BS. For a large malignant cyst with the mass effect, if patient now willing for surgery, any other treatment option, patient is not willing for surgery, what is the option?
If there's large malignant cyst with a mass effect and patient is not willing for surgery, the treatment options are primarily palliative rather than actually any definitive therapy. They are not candidates for any US intervention. US interventions can only be done for benign cystic lesions, not for malignant cystic lesions.
Okay, so radiation can be given. That is another important thing, because many of the patient who has a mass effect and they involve the bile duct, and when you put a stent, and these stents get blocked because of the mucinous material. So giving the radiation to the mass, that is going to prevent the blockage as well as progression of the malignant cystic lesion. Another question. Yeah, please.
Please, no, you're saying something. Sorry, another question.
So how will you differentiate a case of atrophic pancreas with the dilated MPD versus main pancreatic IPMN versus chronic pancreatitis?
That's a very interesting question, and we didn't put up that picture, but we wanted to highlight this. Dilated ducts can be there both in chronic pancreatitis as well as in IPMN. Dilated ducts without obstruction, definitely we're looking at an IPMN. In chronic pancreatitis also, if there's dilated duct but without a side branch dilated around the site of the dilated duct, then suspect that possibility we are dealing with an IPMN. So without side branch dilated duct, without side branch dilatation, suspect IPMN.
Okay, so Dr. Sudipta, the question from my side, so many molecular marker has been advised panel. and when you send the panel, it costs minimum 20,000 or 16,000 rupees.
Absolutely.
Which is the most important indication where you feel when I'm aspirating the fluid, I should send for the molecular marker, or this is should just be used as a research protocol? What is your take home on this?
Okay, so as of now, I will tell you our practice. We do not do molecular markers in patients with cystic lesions, primarily because of the cost constraints involved. But if I had the liberty of using it, I would try to use it in cysts with worrisome features, especially the four markers that we spoke about. That primarily because that would help us determine whether you're dealing with a malignant or a non-malignant lesion. Using GNAS will only tell us whether there's a mucinous or non-mucinous lesion. KRAS will only tell us mucinous, non-mucinous. But the four gene mutation that we spoke about, that's what we would actually like to add on to our panel to say whether there's a malignant or non-malignant. That's the whole point. Are we dealing with malignant, non-malignant? That would determine the treatment outcome.
So young patient who has a good productive life and has a worrisome features, and
Absolutely.
you want a decision, should this patient should go for a surgery or for this? Now another question, what are the indication of pancreatoscopy? When you will advise a pancreatoscopy in a case of IPMN?
So pancreatoscopy in IPMN is primarily to assess the extent of the disease and look for multifocality of the disease. As discussed in the slides earlier also, this really helps in improving in changing the surgical approach to the thing. Now, most of the centers have moved to routinely in preoperative pancreatoscopy just to determine the extent of the disease. If I have to use it, I would use it when I'm suspecting multifocal disease, where there is a diffuse enlargement of the main pancreatic duct. And I want to make sure that this diffuse enlargement is not only because of a mucin plug occluding the entire duct, and it's because of a multifocal nature of the disease. So when there's a diffuse ductal dilatation, that's where I would prefer to use the pancreatoscopy.
So I think that is very important message. The duct should be dilated because in IPMN, the duct will definitely 10 millimeter. But suppose the IPMN is located in the body and tail, and your duct is normal in the head, then you should not do a pancreatoscopy. You will end up into a pancreatitis. So the duct should be dilated. Very important.
Now, suppose the pancreatoscopy is not available, what is your next option?
Suppose a pancreatoscopy is not available to determine multifocality, MRI is a very good option to determine multifocality. So is US, sir.
What about the frozen section during surgery?
That is routinely done by surgeons, sir. That is routinely done by surgeons.
Another question, Dr. Sudipta, from my side. You have shown endosonomorphological criteria of malignancy, like a size of more than 4 centimeter, thick septa. So how many features should be there? Suppose a patient has a one feature. Will you call it as a malignant? How many features you are going to include where you say, yes, the possibility of a malignancy is high?
So all these, hello, can you hear me? Yeah. All these features have been extensively evaluated in multiple studies. And one interesting one, two of these are very, very important. One of them is the thickened septa, especially in an MCM. With a thickened septa of more than 2.5, the odds are almost to the tune of 3 to 4. But if you have an enhancing neural nodule, the odds of detecting a malignancy goes up. So if you ask me, the combination that I would look for is a thickened septa, presence of an enhancing neural nodule. That would definitely raise alarms for me that we are dealing with a malignant mucinous cystic neoplasm.
What about thickened walls, Sudipta?
Thickened walls are there, sir. But the wall thickening is sometimes variable and not a consistent feature. But that has been considered as a worrisome feature, sir. But if you ask me specifically in US, if I'm looking at two major features, would be the septa, neural nodules, sir. Thickening of wall, ancillary, sir, for me.
Dr. Sudipta, very pertaining question. All guidelines, all literature says a patient of serous cyst adenoma, he don't require any surveillance. But there are less than 1% of cases, as you have shown in your slide, these patients develop serous cyst adenocarcinoma. when you are going to suspect that this patient has serous cyst adenocarcinoma?
The risk of serous cyst adenocarcinoma is particularly high when a person has got a VHL mutation. That's the one area where, so as Dr. Matthew's question was that do you need to survey all cysts? No. But if there is a serous cyst adenoma in the setting of VHL, then one should raise an alarm that we are probably dealing with. If there is a solid area within a serous cyst adenoma, then definitely we are probably dealing with a malignant transformation of a serous cyst adenoma to a serous cyst adenocarcinoma.
Okay, so question is, what are the indication of surgery in the serous cyst adenoma? Question from Dr. Matthew Philip.
If
Indication
the
of
lesion
surgery.
for serous cyst adenoma, the only indication of the surgery is if the patient is overtly symptomatic. And the cyst is in the head of the gland, obstructing the duct, and definitely we would consider surgery. But otherwise, there is no other indication to offer surgery for incidentally detected serous cyst adenomas.
Another practical question, a 35-year-old female visit you in your OPD and she's carrying a CT scan with a cyst in the body of the pancreas, which is 2 centimeter. You did endoscopic ultrasound, it is a unilocular cyst. Now, how will you follow? She's 35, going to survive minimum for 75 years. What is your recommendation? Because this is a very common problem which you come across.
The cyst size, as you said, is 2 centimeters. Am I correct, sir?
Yes.
So first thing, when they come in with a CT scan at our institute, we just order an additional MRCT, which is a very, very cheap test. We do not do an EUS in those patients in the first instance itself. MRCP cost is much, an isolated MRCP is much, much cheaper. And that delineates the cyst communication with the duct, the content of the cyst. That's the first line that we do in our setting. And even after at the 2 centimeter cyst, if the cyst is anything between 2 to 4 centimeters, we keep them on a yearly follow-up with an MRI. And just an MRCP, primarily to look for ductal cyst size increase, change in cyst caliber, or developing of worrisome features in the first 3 to 4 years. After 3 to 4 years of interval, if the patient has not further changed in the size or the cyst has not shown any worrisome features, then the patient is followed up can be delayed for a length of time.
Okay. So another question from Dr. Lal Krishna. How a experienced pancreatic cyst RFA? What is your experience of pancreatic cyst RFA when you are going to do it?
I have zero experience on pancreatic cyst RFA, sir, and I probably may not be able to explain this question. I know the theory behind it, but I do not have the practical knowledge of it.
So another question from Dr. Lal
Maybe
Krishna.
you can add, sir, Dr. Rajesh, if you can add to it, because I have not done pancreatic cyst RFA.
Okay, so I'm just going to talk. So another question from the Lal Krishna, what are the difficulty faced during cyst puncture? Suppose cyst near the vessel.
Avoid puncturing the vessel. It will only contaminate the content of the cyst and aspirate, and therefore would lead to erroneous results. Even the glucose reports will be erroneous. So try to puncture at a site which is predominantly avascular. Number one. I prefer to use a 19 gauge needle. If it's a mucinous lesion, it is very easy to aspirate with a 19 gauge needle rather than a 22 gauge or a 25 gauge needle. And I put the suction at the first instance when I'm inside the cyst and thereby aspirating the content of the cyst. If there are multi-loculated cysts, then the cyst that I have punctured, I try to aspirate the full content of the cyst itself.
Okay, another question from Dr. Nand Kumar.
Yes, proceed.
Chat box has disappeared. Another question from Dr.
Is there with me?
Yeah, another question from Dr. Nand Kumar. Index presentation of span in the first trimester. How do you go about? What are the risks of cyst rupture if decide to wait and watch? So first trimester.
Yeah, I think this is a very specific question in a situation, and it's very correctly put out also because pain does affect young women, and that is a challenge. But whenever we've had to face the circumstances, we try to delay the surgery till the delivery of the baby is done. Pancreatic surgeries are not always easy. Even if the stent is in the mid body and you do a central pancreatectomy, there's a risk of leakage. Whipples obviously has its own complication. So therefore, we try to avoid it at the till the completion of pregnancy.
Then question is, do all span require resection?
Stent, which is symptomatic, yes.
Okay. Another important question, if the patient is asymptomatic, then you will not do surgery in the span. A 32-year-old female came with the mass in the pancreas, you do an FNB out to be span.
Most often than not, stent actually are symptomatic. Patient usually come in with abdominal pain. That's a very typical presentation of stent. It's very unlikely that you'll get a stent which is asymptomatic actually. And whenever you have when you're talking about asymptomatic, then the protocol for follow-up just moves into the asymptomatic arm itself.
Okay, and once you have done the resection, how do you follow? Because these patients has a recurrence of the span.
Span, as such, there is no specific follow-up diagnostic guidelines for span. Most of them are unifocal, so risk of multifocal disease is also low. So there is no particular guideline to follow up span per se. Surgeons in our center prefer to do a repeat imaging at 1 year interval and then every 3 years.
Rajesh, we have 5 more minutes. Then we have to wind up.
Tail lesions.
So the tail lesions, how the strategy for the EUS aspiration? Tail lesions, Dr. Lal Krishna.
That's an interesting question because the tail lesions have it's because you have to go through the fundus of the stomach. There's a risk of puncturing the spleen adjacent to it. So one has to be careful that we should do it only when it is indicated. Number one. Number two is that if you are doing a tail lesion, try to focus your scope as far away towards the tail of the pancreas, and as you go there, make a single puncture, avoiding any blood vessels or the splenic parenchyma. These are the two things that I would recommend.
Can I add to that, Sudipta? Suppose there is a lesion in the tail of pancreas, which is otherwise an indication for surgery. There is no need of doing an EUS, FNA or aspiration. That we can straight away send the patient for surgery.
Of course, yes, sir. Of course, yes, sir. Of course, sir. Whenever there is an indication for surgery, EUS does not come in at all, sir.
And in head of the pancreas, if there is a doubt, it is a borderline, then I think, you have to take it for a larger surgery, like a very complicated surgery like Whipple. In that case, I think the threshold for EUS actually is different. So in tail lesions, it is different, and in the head region, it is slightly different. So what is your opinion on that?
So I agree with you completely, sir. And as I said earlier, also one should intervene with EUS only when the treatment is going to change, when the intervention is going to change the management of a patient. Otherwise, there is no particular indication to intervene, sir.
Rajesh, any more questions you want to discuss?
Yeah, so the answer to the question which was asked, how I experience pancreatic cyst RFA. So there are literature available where the people has done the cyst RFA, especially patient with the solid lesion with the NET, ITMN, MCN, and those patients who are either not the candidate for surgery or refuse for the surgery. In those group, a cyst RFA was done, and there is a short-term follow-up shows it has a very good results, but require more studies and more follow-up. So cystic lesion in the form of neuroendocrine tumor, in the form of ITMN or MCN, those who are not willing for surgery or has comorbidity, but you feel they have a good expectancy of life, you can do EUS-guided cyst RFA ablation.
If we have completed the questions, I just wanted to, any more questions, Rajesh, or any chat box? I think now it's time for us to stop now. And we have the Thanks a lot, Dr. Rajesh, for nicely conducting this wonderful session. And Sudipta Dhar Choudhary, it's actually you have shown everything under this label of cystic neoplasm. Very concisely, you have told, and you have given a very practical approach how to do that. The most interesting thing was you have shown an algorithm which can be practiced in your setup or anybody's setup, and you have amalgamated all the guidelines and made a guideline. And take home messages are wonderful. I am sure the students as well as the young faculties, young gastroenterologists who are listening to this has benefited a lot. I learned a lot from this, and thanks a lot. And we have thanks Rajesh for taking out your time for on this Sunday, and I'm sure you are on another meeting, and this is really wonderful. So we will have the next session on June 16th. It's a very important session on pancreas, and Dr. Pramod Garg is going to speak on that. Dr. Sandeep Lakthakia is moderating on that, and please do join and stay tuned on this. So thank you so much. We are signing off now. Thanks a lot. Thanks to the my president, Dr. Govind Makaria, for all the support is generating on this, and also the person from IST, Nisha, who is taking a lot of interest on all these things, as well as the technical team, which has made everything possible very smooth. And I also thank all the people of delegates who have joined for this meeting. I am sure you will benefit a lot on this one. So ISC is having this program continuously. Please tune on for this program and look at that and join early enough to learn a lot. And this YouTube will be available after a couple of days in our ISG website as well as in ISG YouTube channel. Thanks a lot. Thank you so much.
Thank you, Dr.
Thank you,
Matthew.
sir. Thank you, Dr. Rajesh.
Thank you. Thank you.
Thank you so much. Thanks.